Good afternoon, sir, and good afternoon for delegates. This is a 28 years male working in a medical store, unmarried, South Country, South India, and rural areas of Belgaum district. Presented with a complaint of multiple joint pain since 2 years, aggravated since last 1 year, symmetrical and adductive in pattern, in nature, no deformity of joints, difficulty in squatting due to the knee pain, early morning stiffness for 2 hours, work the joint pains increases, rest joint pains reduces, low back pain, bilateral since from 2 months, pain is not aggravated, no radiating pain or early morning stiffness, and also complaints of fatigue. No extra manifestation like fever, cough, weight loss, or eye symptoms. There was a skin manifestation was presented. Hyperkeratitis with hyperpigmentation border of a lateral side of right in foot since from 10 years. And also there was same in the left foot, hyperkeratitis in a left lateral side of a in foot and lateral malleus since 3 years. Small ulcer over a right lower leg, no oozing or pus discharge since 15 years. Ulcer is painless. This was a face which was presented to us. Changes. And we see the face changes and lesions over the foots. No history of fever or injury in the right middle finger. No history of bowel and bladder involvement. No weight loss. Past history as a nasal polyp underwent a surgery in January 2020, June 2023. Personal history, no alcohol or smoking. Family history, nil. Treatment history was on Vislon 10 mg into 2 months in December 2022 to February 2023. Okay.
So I missed the age of the patient. What's the age?
28, sir.
So there's a young male with polyarthritis with back pain. Correct, no?
Back pain and polyarthritis.
So would anybody have would like to discuss the differential diagnosis in this patient? The underlining point is young age and male. This face we will keep a watch. We'll let it be there.
Okay, fine.
So they're very good, sir. Spondyloarthritis should be high in your differential diagnosis because this is one thing which can link young male and back pain and polyarthritis. All these things can occur in this combination. Would anybody want to comment on this phase? Sjogren syndrome, we cannot make it, it is, and I can't, typical symptoms are dry eyes and dry mouth because we are not seeing eye redness, even we are not seeing the eyes or we are not seeing the mouth to. Chanchakar, you know what because I can't. Little coarse features, what I can think of. Castle bridge. So this has not come out very well, but this bridge seemed to be a little collapsed. There seemed to be a dip here, and little bit of swelling in this ear, I guess.
Yes. Earlobe thickening. And then non-healing ulcers. What about the other findings? Any thickened nerves or anything?
Leprosy should be in the differential diagnosis. And another differential diagnosis, rheumatological differential diagnosis will be relapsing polychondritis because people can have polyarthritis, back pain may be non-specific, and people can have this kind of a cartilage picture. Wegener's granulomatosis is another diagnosis.
The past history of a nasal polyp being removed, that may be the cause of nasal.
That could be the reason for the bridge collapse. It could be a misadventure with the surgery. So we need to keep both things option open.
Because the information available to you is available to me also. I'm trying to look at the differential diagnosis. So a young male with an arthritis with little coarse looking facial features, with changes in the ear and nose nasal bridge, with an ulcer, chronic ulcer in the leg. So we should think of Hansen, and if we ignore the ulcer, we can think of relapsing polychondritis, we can think of granulomatous polyangiitis or Wegener's granulomatosis in the differential diagnosis. I don't think so, sir.
There was no toe 5.
No, no toe 5. No toe.
From what we can see, probably no.
Patient responses alert and oriented.
I think since there's a general audience, it's good to look at associations. So what are the conditions where you get arthritis with skin disease? So very commonly psoriatic. I tell my PGs there's no blood test for psoriatic arthritis. You just look at the patient, make a diagnosis. Other associations, joints and skin. When you get a history, you can just try to make a diagnosis before you reach the examination. Any other conditions? Females, I'll give a clue if it is a female. Lupus, not so common, quite a rare disease, but you may have a referral bias if you're sitting in a rheumatology clinic. Of course, you'll get more patients. Dermatomyositis, that was my first thought. Actually, the images are not very clear. One of the thoughts I had was dermatomyositis. Extremely rare diseases, but a very good way to think when you see a patient or when you get a history. Make associations, skin and joint, and you can think of these various DDs. And Hansen's, we should be all familiar as Indian physicians, but we often forget all about it.
And ear cartilage changes are seen, vitals were normal, and CVS was normal, chest clear, abdomen was normal, sir. CNS, mental functions was normal, peripheral nerve, sensory reduced in the bilateral, plantar region and foot, no nerve thickening of ulnar, perineal or auricular, grip of bilateral hands foot was normal. Summarization, polyarthritis, back pain, ulcer over the bilateral, over the left lower leg, lateral aspect, hyperkeratosis, skin lesions in bilateral in foot, sensory reduced in the bilateral foot and sore, red, scaly and skin thickening, skin itching over a bilateral thigh and hypopigmentation and itching over the over abdomen.
Yeah, now, I think after this much of information, any more wisdom, anything new which you could consider or... I think there is a sensory loss and there are ulcers. So where the priority of the first possibility with that facial features is Hansen's. The second possibility is a vasculitis, possibility of Wegener's. It's because there is a nasal bridge collapse. The ear involvement can also sometimes rarely happen. Facial changes can be there, but neuropathy is also can be seen with a recalcitrant ulcers, which is other possibility. And the next alternative rare possibilities are next. So clinically we first thought as Hansen's, and other alternative differentials we had is it could be rheumatoid vasculitis, Wegener's or PAN. Any other additions if you can?
The list looks reasonably okay. The only question is the ear involvement. Or what did you see in the ear? Can you describe the ear? Was it thickened?
Thickened, sir, little bit thickened, but our nerve was not thickened, sir. Only the cartilages was thickened.
Okay. I think I would probably limit this here in the differential. Anybody would like to add anything? And the point is the ulcer is there, supposed to be there for many years. So in an Indian population who have a habit of sitting cross-legged, sitting in the floor, they can always have a little bit of callosity in the lateral malleolus, sometimes which can ulcerate. So which can be a non-specific finding in many of the people. Many a times when we have arthritis, in a patient who practices Islam, if we see little darkened pigmentation, we always jump that it could be psoriasis. Sir, I daily do namaz, that's the reason I got it. So sometimes we have to use our common sense, and beyond that, I think the Hansen disease should be there in the priority. And of course, rheumatoid arthritis, unless we have little more details about the nature of arthritis, whether it is boggy synovitis, then only we can really make a difference. But I think Hansen, with the possibility of a rheumatic disease like vasculitis will be in the differential diagnosis.
I'd just like to introduce a term here. A famous person in 14th century called William of Ockham has put out a principle called Occam's razor. Can anyone tell me what is Occam's razor? OCCAM. Occam's razor. Razor is just a wise statement. It is a very classical case here. Occam's razor says that if you have multiple manifestations, put them into one box. And the only thing that fits one box here is Hansen's. So the theory says if you have two competing ideas to explain the same phenomenon, you should prefer the simple one. So you can call it rheumatoid, you can call it pan, you can call it vagus, but if you combine everything with the ear nodules, you call it Hansen's disease. It's just a term you can look up. As physicians, we should know what is Occam's razor.
Good to know a new term today.
Serology, ANA was negative, anti-CCP, RF negative, urine routine normal, ESR 8, CRP 14 mg per liter, SGOT, SGPT 95, 194, alkaline phosphate 94, GGT 171, HP 14.1, total count 5420, neutrophil 75, lymphocyte 70, platelet 3 lakhs 8,000, creatinine 0.6, rheumatoid factor was negative, total bilirubin 0.04, direct bilirubin 0.3, indirect bilirubin 0.6, urine routine was normal, KH was positive, viral markers, hepatitis B, hepatitis C was negative, chest X-ray was normal, done outside.
Now, I think here the investigations almost excludes the other alternative possibilities because most of the autoantibody response were negative and persisting ESR. Only thing which we need to look at and explain is the liver function abnormalities. And the patient history-wise was already received some steroids, some NSAIDs. That could be one of the reasons, or we need to figure it out, is there any additional issues which reference to the liver? And of course, that keeps the things open that we need to see there is something more, because in a simple Hansen's without a reactions, you don't expect the elevated or altered liver function test. You need to keep the liver function test, what is observed in the investigations open.
This KOH positive is from the groin lesion?
No, sir, it was in thigh, sir.
Thigh lesion. So that obviously, that's obviously a fungal infections. So that is probably you can keep it aside, treat it separately. And the inflammatory markers are normal, autoantibodies, whatever is available, they are normal. CRP is also slightly higher, slightly high. Okay. Abnormal liver enzymes. So we can look at few conditions where it can cause joint pains and liver function abnormalities, or diseases which can cause transaminitis and arthritis. Any suggestions? We are just looking at like a differential diagnosis. Hepatitis B prodrome can have a symmetrical RA-like polyarthritis. Some of the seniors who used to see hepatitis B, acute hepatitis B, you get a serum sickness like illness, urticaria arthritis syndrome, which is fortunately thanks to vaccine, it has almost disappeared. When we were starting, I used to see almost one patient or two patients every few months, like a serum sickness like illness, and it turns out to be hepatitis B1. And rarely hemochromatosis can cause arthritis, more of osteoarthritis type of presentation. And some of if the GGT is normal here, if SGOT is more than SGPT, would you think of anything else? In this patient, SGPT is more than SGOT. If SGOT was more, say SGOT was 200, SGPT was 99, and patient has an arthritis, would you chase the liver or will you look at other organ? We should think of a muscle as a potential cause for this transaminitis, because both ALT and AST are muscle enzymes as well, where you will get more AST or SGOT more than SGPT. Last week, there was a patient who was referred from Bihar with persistent liver function abnormality. SGOT was some 300, SGPT was some 150, and patient had few doctors there. They came to a gastroenterologist. Gastroenterologists have extensively investigated, did a liver biopsy also. Then after that, they have done a CPK. CPK was 2,500. The patient, obviously, if somebody has spoken to the patient had difficulty from sitting and getting up. She always say, I have difficulty in walking. And she turned out to be some kind of a hereditary, some inherited myopathy. Her father has similar problem, and one aunt has a similar problem. This was a story. But the patient had spent up to liver biopsy before somebody thought about a muscle. Sometimes we get fixated based on the investigation. So it is better to always correlate the history with the test and then act further. If somebody has asked a question, somebody is weak, somebody would have done a CPK. Then you have an explanation for liver function abnormalities.
Local examination, extensive hyper and hypopigmentation rashes with itching over a bilateral thigh and lower abdomen since 5 years. Mild numbness over a bilateral foot and plantar region. Episodes of burning sensation of bilateral palmar and plantar regions. It's okay. Hyperkeratosis with hyperpigmentation border of a lateral side of a right infoot. Hyperkeratosis in the left lateral side of infoot and lateral malleolus. Small ulcer over a left lateral side of leg. No oozing or a pus discharge. MSK normal, no tenderness or swelling of the joints. X-ray pelvis and X-ray of both hands. Histopathology reports. Skin biopsy shows a future with Hansen diseases, mild moderate type with a bacillary index of 4 suggestive clinical correlations. And if you have been done, sir, negative for IgG, IgA, IgM and C1q. There were a faint granular deposition of C3 along with the vessel spots.
I think the diagnosis is quite obvious. It's Hansen's, probably type 1 reaction. And we need to remember that we have not still got over of the Hansen's and tuberculosis. These infections can anytime mimic your clinical presentations. You can have MSK presentation, you can have iridocyclitis, you can have skin lesions, you can have varieties of lesions. These are common diseases which have still not come over. And what was little surprise, which might have taken everyone, is he's a young patient, 28 years, working in a pharmacy. So probably everybody would have considered, because till this point, patient was treated with NSAIDs, even to the extent of adding prednisolone, episodes of DMRs being used. So quickly says that you need to keep things open, that an infection can mimic a possibility of allergic diathesis, or a musculoskeletal disease, or a combination thereof, or even sometimes the vasculitis.
Dr. Devaraj, would you like to tell the audience what you did about the steroid treatment? What is the approach to this patient, even if he has Hansen's?
Steroids, sir.
In this case, what was done? I'm asking what was done about his steroid. You can't send him to a government hospital, you have to give some advice about the steroids.
He was stopped 3 months back, sir. He was already stopped before coming to us. He was stopped 3 months back, sir.
Yeah, but what Dr. Jacob was coming to was a very important, pertinent question. And people, the moment they steroid, abruptly, stop, this is a poison, you stop. Sometimes people make them feel so guilty that they stop abruptly. But somebody is on steroid for, say, a year or two, with 10 milligram, 15 milligram steroid. The moment you stop, they become sick. They have a very high potential of developing Addisonian symptoms. So we need to be aware of this fact. And if somebody is on a long-term steroid, it is better to taper, whatever be the condition, rather than abruptly stopping. If you are stopping it due to an infection, say if somebody is on 10 milligram steroid, patient come to you with the pneumonia, you stop, and he will worsen, because during acute stress, you need more steroids. And your body's ability to produce steroid is less. The patient will develop hypotension, and your ICU doctors will see that sepsis and put them on noradrenaline. They will end up being stuck to ICU. So unless somebody gives you hydrocortisone, you will not recover. So this is a very important point for any clinician to remember. If somebody is on a long-term steroid, please taper it off rather than abruptly stop it. Whatever be the reason where you are forced to stop. coarse feature
Yeah,
of Hansen, I think.
Hanson's, exactly.
It is shiny face, the so-called leonine, early leonine face.
It's a classical face because actually speaking, before I speaking to him, as soon as I saw the face, the first differentials we had was Hanson's. Let's work up for the Hanson's. That photo we wanted to put somehow, I think, LCD screen.
Little shiny face, a little coarse features.
It's a class Hanson's description which is there.
Okay, sir. That's why the laparoscopy minimic like RA, spondyloarthropathy, I think already was spoken. Sir. Okay, thank you, sir.
Thank you, Dr. Devaraj.